So today, as you noticed, we're talking about ventricular septal defects. This is a pretty straightforward topic, although the terminology used here can be a bit confusing. It's probably maybe second most after bicuspid aortic valve, most common congenital defect, roughly 20% of congenital defects. And it's the one that's most often associated with chromosomal anomalies. So how do these present? Well, most of them with a heart murmur. And the heart murmur of ventricular septal defects is usually first heard on the second or third or fourth day of life, or even later. Virtually never on the first day of life, because the pulmonary vascular resistance is still a little bit high at that point, usually on the first newborn exam. And if it's a big defect, it can produce heart failure symptoms, so rapid breathing, poor feeding, lethargy. These usually start, if it's a sizable defect, somewhere in the first weeks of life, 3, 4, 5 weeks, something like that. Babies seem hungry, they want to eat, but they tire out quickly, they fall asleep, and so they tend to not grow very well. On the other hand, if it's a small defect, the babies may be completely asymptomatic and just have a murmur. So on exam, you may see tachypnea if it's sizable, hyperdynamic precordium, because this is a volume overload lesion. It's mostly a left ventricular volume overload lesion. And so you may also see a thrill along the left sternal border, or even to the right of the sternum sometimes, because of flow across the defect. The first heart sound is usually normal. The second heart sound may be normal, or if it's a big defect where there's pulmonary hypertension, right ventricular hypertension, the second heart sound may be single or very narrowly split because of the pulmonary hypertension. There's usually, as we said, a murmur, a holosystolic murmur begins with the first heart sound at the left lower sternal border and often radiates across to the right chest. There may be a diastolic murmur, diastolic rumble at the apex. This usually means that the QPQS is at least 2 if you can hear a diastolic murmur at the apex. That's from excessive flow across the mitral valve, since most of the volume work is being done by the left ventricle. So when the shunt flow returns to the left atrium and goes across the mitral valve, you can hear often a diastolic murmur. There may be hepatomegaly. Pulses are usually normal, although some patients with VSD, of course, can have a coarctation, but most don't. Then the electrocardiogram usually shows either biventricular hypertrophy if it's really big, again because of right ventricular hypertension. There may be large mid-precordial voltages, and it's normal, of course, if the VSD is rather small. Chest X-ray here is a baby with a big VSD. You can see there's a sizable heart. There's some fluffiness out here in the lungs from increased pulmonary blood flow. And the other thing you notice is hyperexpansion. You see the diaphragms are pushed down here. Babies with big left to right shunts, whether it be a complete common AV canal, a big VSD, truncus, whatever, with a lot of pulmonary blood flow, often have hyperexpanded lungs. The diaphragms are flattened and descended quite a bit, and that seems to be because of air trapping, because of dilation of pulmonary blood vessels that run alongside bronchi and may compress the bronchi and result in some air trapping, some emphysema sort of picture. So this is a fairly common finding in patients with a big left to right shunt. So when we talk about ventricular septal defects here, we're interested in helping the surgeon figure out where the defect is in the septum so he or she can close it. And so we think of these geographically, at least I do. I think about an inlet VSD, or what's often called an AV canal type VSD, as being here. We're looking here into the right ventricle against the septum. We've removed the anterior wall of the right ventricle. This is the septum down here, and this is the septal leaflet of the tricuspid valve in this cartoon. So all behind the septal leaflet is the inlet septum, or AV canal septum, and the membranous septum is right at the top of this. So this is an inlet defect, an inlet or AV canal type. Membranous defects tend to be here at the commissure between the septal leaflet and the anterior. If you can imagine the anterior leaflet coming out like this over here in front, and then the inferior or posterior leaflet would be down here. So at this commissure is exactly where the membranous septum is. And so membranous defects, the membranous septum is relatively small. So if it's just confined to the membranous septum, it would be a relatively small defect right here at the commissure between the septal and anterior leaflets. Very often these extend either apically or inferiorly into the inlet septum, or occasionally up into the outlet septum, because the membranous septum forms by fusion of the infundibular septum or outlet septum here with the superior endocardial cushion. And so if there's some deficiency of the outlet septum, not complete, but some deficiency so that it doesn't fuse with the superior endocardial cushion, then there's a membranous defect, but you may also have a little outlet extension, or you may have membranous defect but some inlet extension or apical extension. So membranous VSDs often involve some of the muscular septum around the membranous septum as well. And then we use the septal band and the moderator band as markers on the septum, as landmarks for explaining where muscular defects are. Anterior defects are up in front of the septal band, the takeoff of the septal band. Mid defects are somewhere between the tricuspid valve here and the takeoff of moderator band. Apical defects tend to be apical to the takeoff of moderator band. And you can think of them as anterior, mid, inferior defects in this view. And you can describe them in an apex to base view as well. So those are muscular defects. And then the other type of defect that we have is a conoventricular defect that's between conal septum and the rest of the ventricular septum. Things like the defect that we see in Tetralogy of Fallot in double outlet right ventricle. Interrupted aortic arch. We'll talk about these more as we go along. Or you can have absence of the infundibular or conal septum, so-called conal septal defect or subpulmonary defect, or doubly committed subarterial defect or supracrystal defect. All of these are the same thing, and that means that the infundibular septum, which is the very proximal part of the fused outflow cushions that divide the old primitive common outflow tract into an aortic and pulmonary component and contribute to development of the semilunar valves. And the part of the ridges, the outflow cushions below the development of the semilunar valves, is what forms the infundibular septum. If that doesn't form, then we have a deficiency here below the semilunar valves. The semilunar valves are immediately adjacent to each other and they're unsupported. The aortic valve can prolapse in that situation. And this is the kind of defect that we see there. And if we look at the septum from the other side, from the left ventricular side, we don't usually do that. We usually think about it from here because this is the way the surgeon's going to look at it. But from the other side, an inlet or AV canal defect is here at the inflow part of the ventricle. And then the membranous septum is here at the commissure between the right and non-leaflets of the aortic valve. Just below the fibrous trigone of that commissure is where the membranous septum is. And then anterior to that is where the little bit of infundibular septum or outlet septum that we see from the left ventricular side. Most of the infundibular septum is a right ventricular structure because we don't have a complete subaortic conus like we have a complete subpulmonary conus. So the only part of that that's left here is just a little bit of the outflow septum right up here under the right coronary leaflet. The left and non-coronary leaflets are the ones that are in continuity with the mitral valve. So there's no muscle under those. There's just a little bit of outlet septum up here under the right coronary leaflet. So you can see that over here on this diagram. Here's the non-coronary leaflet. Here's the left coronary leaflet. And this is the right. You can just see the right coronary back there. This is the commissure. Here's the membranous septum right there, just below that commissure. And the outlet septum is this part up here, just this little part. It isn't well demarcated on this side like it typically is on the right side. You can see the outlet septum on the right side here in the Y of septal band, but it isn't so well demarcated. It fuses in much better on the left side, so you just get a little hint that this is the outlet septum up here under the right coronary leaflet. So we can think about the kinds of defects that we see. An inlet or AV canal type defect here, as we said before, and what that looks like on the echocardiogram is this. Here's a peristernal short axis view, and here's the defect right here. Here's the tricuspid valve up here. Here's the mitral valve, and you can see all of this septum between the two atrioventricular valves back here is missing. There's a big defect right here. So we've got a big AV canal or inlet type of ventricular septal defect. And we can see this very well from an apical view as well. Here, this is the septal leaflet of the tricuspid valve that's bowing over here. Here's the anterior leaflet over here. And you can see there's a big defect here behind the septal leaflet from here all the way up to the crux of the heart. This is all missing. So this is a typical inlet or AV canal type defect. You guys want to mute yourself, whoever just joined us? So if we look at this from a subxiphoid view, here's left ventricle, here's right ventricle, here's the ventricular septum, and as we scan inferiorly, there's the defect right there. It's very inferior, very adjacent to the AV valve annulus, to the tricuspid annulus. You can see flow coming across it right there. So this is an inlet or AV canal type of defect. And then a membranous defect, as we said, an isolated membranous defect is up here, but you can have extension in various directions. So it's at the commissure between the anterior and septal leaflets of the tricuspid valve. And here's an example of a small membranous defect right here. See, here's the septal leaflet down here. Here's the anterior leaflet. That's the commissure right there, and that's where the defect comes across. It often divides at that point into an inferior jet and a more superior anterior jet up here. As it comes across, it's divided by the tricuspid valve. So that's a typical relatively small membranous defect right here just below the aortic valve. And then if we look at this in a peristernal short axis view, remember we said it was just adjacent to this commissure between the right and non-coronary leaflets. There's the right non-commissure right there. And when we turn on color, you'll see that the jet is just immediately below that commissure right there. So that's a nice marker for the membranous septum from the left ventricular side from a, say, a peristernal short axis view like this. And then in an apical view, if we scan inferiorly, this is where we saw that inlet defect before, but it's all intact back here. That's all the way back to the inferior wall right there. Now we're coming up anteriorly. Here's tricuspid valve, there's septal leaflet, and there's the commissure, and there's the defect right there. And there's aortic valve. Then as we scan up more anteriorly, we get up into the outlet septum, and it's intact up here. There's the pulmonary valve all the way up. This is the anterior muscular septum, outlet septum. And so there's the defect right there, a typical membranous defect right there. There you can see the little jet coming across. This is relatively small and restrictive. And the same thing on an angiogram. Here's a nice left ventricular angiogram and a long axial oblique projection. You can see it profiles the outflow up here into the aorta, and here's our membranous defect right there. This is, again, a small one, You can see there's a relatively small membranous defect right there. Now, sometimes you can see formation of a big aneurysm around the membranous defects. This is a particularly large one, and it's closed, this defect, in fact. And sometimes these can cause right ventricular outflow tract obstruction. They can be big enough. This patient had a little gradient, but it wasn't much. So here's the same thing again. You can see this big aneurysm, and this is the septal leaflet of the tricuspid valve. So you can see it contributes to the aneurysm, but then there's some extra tissue that's formed here around it that's actually closing the hole. Here's the hole. You can see it right there. Again, right at the commissure between the right and non-coronary leaflets right there. And then this is what's closing it. And if we put color on, you'll see that you really don't get any flow through this because the aneurysm has essentially closed it. See, there's just a little flow in and out of it, but nothing through. And then there's a little gradient up here in the right ventricular outflow tract between the aneurysm and the free wall. So that's how these close, if they close spontaneously. And here's an angiogram of one that's closed. And there you can, again, see the aneurysm that's formed around this little defect. Now, in transposition, what can happen is that the membranous septal aneurysm or the septal tricuspid leaflet can bulge into the left ventricle. Here, you can see it bulging over here, causing subpulmonary obstruction. We don't see this much anymore because we do arterial switch operations very early in life, and so you don't really see that, but that can happen in transposition. We used to see that regularly. And then conoventricular defects are between conal septum and the rest of the ventricular septum. Here's one. This patient happens to have transposition. This is aorta and pulmonary artery. This is infundibular septum. Here you see the superior most attachment of the tricuspid valve. That's the inferior ramus of septal band. And so this is between the infundibular septum and the rest of the septum. There's a little overriding of the pulmonary root in this case, not uncommon in some patients with transposition and this kind of ventricular septal defect. But you can see it's between the conal or infundibular septum above and the rest of the ventricular septum below. And this superior attachment of the tricuspid valve is the marker for the junction between the inflow part of the septum and the outflow or infundibular septum up here. This is the kind of defect that we see in tetralogy, and here you can see anterior deviation. Here's the infundibular septum that's deviated up here under the pulmonary valve, too close to the free wall, causing subpulmonary obstruction right there. You can see how it gets close to the free wall. Now, aorta is overriding because the infundibular septum is up in the air here above the right ventricle. So this is a type of conoventricular defect where we have outflow tract obstruction and tetralogy. Now you can think of this as sort of the mirror image of that, and that is where the infundibular septum, instead of going toward the front under the pulmonary valve, goes to the back over the left ventricle under the aortic valve. This is what we see in patients with interrupted aortic arch. And here you can see an example. There's aortic valve. This is the infundibular septum. It's often thin and fibrous when it does this. Here's the defect. There's pulmonary valve up here. So you can see how this causes subaortic obstruction. The infundibular septum traps the outflow between it and the medial leaflet of the mitral valve back here and causes subaortic obstruction. That's one mechanism. In transposition, you can have the same thing with subpulmonary obstruction. So here's infundibular septum deviated back under the pulmonary valve, but again causing now subpulmonary obstruction because this is transposition. Aorta is up here, PA is back here.
Do we still call that tetralogy?
What, this?
Yeah,
no,
when it's transposition, and there's...
This is transposition VSD and pulmonary stenosis. Because this is the...
But it's the same disease, I guess it's coming from the LV, so not really.
Yeah, it's coming from the LV, so this is a bit different than what you would see in tetralogy, right?
Yeah.
And there's no... Go ahead.
I was going to ask, why is it that we see just type, or most commonly type B interruption with the posterior malalignment? VSD?
I don't really know. I suspect it has to do with the fact that this is what's associated with the George syndrome, and that's most commonly what's associated with interrupted aortic arch. Type
Gotcha.
Cs are very rare and usually associated with aortic atresia. And type A is relatively uncommon. We see it sometimes in transposition, but without so much deviation. Sometimes you can see type A's with no VSD at all, interestingly.
Thank you.
Yeah. So this is a 3D echo of a patient with transposition VSD and PS. Here's the aortic valve up here above the right ventricle. Here is the mitral valve back here. And this is the ventricular septal defect. This is infundibular septum. There's a complete subpulmonary infundibulum here. There's a ring of muscle, and then you can see the valve up above that. And if we let this move, you can see the valve up there, and you can see how this narrows dynamically during systole because it's muscle, it's infundibular muscle that's causing subpulmonary obstruction. This is infundibular septum that's deviated back under the pulmonary valve like that. And then you can have absence of the infundibular septum, a conal septal defect or doubly committed subarterial, and these are at risk for aortic valve prolapse. So here's one right here. Here's the aortic valve. And then we can scan right to the pulmonary valve and never see any muscle in between. Aortic valve, and then there's pulmonary valve, and you never see an infundibular septum in between. Or in short axis, here's the defect right here. It's up around noon instead of being over at 9 or 10 o'clock like we would see a typical membranous defect. This is up between 11 and 1. If you want to think of the aortic valve as a clock face like that. So there you can see it. And you can see the pulmonary valve here, the aortic valve there, and there's no muscle ridge, no infundibular septum. In tetralogy, remember we saw that big lump sticking up here, but in this case it's absent. There's nothing here. Here's aortic valve, here's pulmonary valve, and there's nothing in between. Or in a long axis peristernal view, here's prolapsing aortic leaflet right there. You can see it bulging up. This is the right coronary leaflet. Here's the non back here. And this is the right bulging through the defect into the right ventricular outflow. This patient didn't have any AI, interestingly, but there you can see the VSD jet, which sort of outlines the leaflet, outlines the cusp that's prolapsing through the ventricular septal defect. And here in short axis, you can see it very well. You see the thin part up here is leaflet. Here's the thick edge of the septum there, and the other edge of septum is right there. And so this is all prolapsed aortic leaflet. This very thin part right here is the prolapsed leaflet like you see here in the diagram or in the specimen. And then you can have various types of muscular defects, inlet, mid, apical, inferior or posterior, anterior. Commonly around where the moderator band takes off, we can see a number of kinds of defects. So here's a one that's closer to the apex, not quite at the apex, not quite like this specimen, but you can see it's a little closer to the apex down here. And then here's one that's quite inferior or posterior, very close to the diaphragmatic wall. And there you can see flow through it as well. And here are a couple of mid-musculars right here. This was transposition, so it's going from RV to LV. And then this is favorite places right at where the moderator band, there's the moderator band coming off. You can see there's a defect right below it right here. There's moderator band up here, and there's the defect right there. And if we put color in that, you can see how it's just adjacent to the moderator band right there. So that's a common location for muscular defects as well. And then you can see bigger, more basal muscular defects. This one happens to have a muscle bundle crossing it. And that's an important thing to recognize because surgeons looking through the tricuspid valve may think that this is the edge of the VSD when really the edge is down here. And if you just close this part, you're going to have a significant residual defect down here. So it's important for the surgeons to understand if they're crossing muscle bundles like this. And this is just another look at this big muscular defect. You can see it's not a typical AV canal defect because there's muscle here between it and the crux of the heart. So here's a muscular defect seen, inlet muscular defect seen on angiography. You can see this is sort of a 4-chamber view. You can see this is a more or less an inlet defect back here in the this part of the septum. Or you can see anterior defects, like on this RAO view. Here's an anterior defect up here, and here's the same defect by echocardiography and color Doppler coming across anterior up here in the anterior muscular septum. So these are the kinds of defects that we see. The diagnostic principles we like to use is high resolution imaging in multiple planes to scan the septum. Doppler color flow mapping is essential. We want a small color box to enhance the frame rate, and multiple slow scans of the entire septum in different planes, subxiphoid planes, peristernal planes, apical planes, to be able to really examine the septum very well. And we use multiple views to localize defects. We want to localize it in an apical to apex to base location. So we use apical or long axis views so that we have a long axis, and then you can tell where it is in that dimension. And then we use a short axis, either a subxiphoid or a peristernal short axis, to localize it in an anterior, posterior, or superior, inferior dimension as well. And both of these are important for really characterizing where muscular defects are. We usually manage these mostly with diuretic therapy. We want to try medical management because a quarter or more of ventricular septal defects will close spontaneously, or at least become small enough that they don't need surgical intervention. So we try medical management for as long as we can. In the past, we used digoxin. I don't think many people do that anymore, but maybe. And there was a time when vasodilator therapy was quite popular. I don't know that many people, do you guys have a sense of what people use to treat VSDs with, besides anything besides diuretics?
I haven't seen anything besides diuretics.
Yeah, I think that's pretty much the mainstay nowadays, is just diuretics to manage this, and trying high calorie feeding and that sort of thing. So we typically use medical management to try to temporize in hoping that the defect will close or get small. But there are clear indications for surgery, growth failure despite medical management. If babies aren't going to grow, they're not going to, you know, what happens typically is the VSD doesn't get bigger. It stays the same, or maybe gets a little smaller. But the baby, as the baby grows, the baby's cardiac output goes up. And so the shunt volume becomes relatively less compared to the cardiac output as the baby grows. And so that seems to be part of what happens in having these defects functionally get smaller. So if babies aren't going to grow, that's not going to happen. So growth failure is one indication. Continued pulmonary hypertension greater than, I would say, half systemic by closing in on the end of the first year of life. I think most people would want to close that defect. And continued left ventricular enlargement by a few years of age may be an indication. And certainly any evidence of left ventricular dysfunction would be an indication. And of course, the options are surgical closure. There's some now device closures are possible for some defects. In some places in the world, that's the primary mode. Although for basal types of defects, membranous defects, those kind of things, I'm not a big fan of that. There have been problems with this, although I think some of these have been worked out. But the surgery has a very good track record. And occasionally we may have babies that we palliate with a pulmonary artery band because of other medical problems or prematurity or something where you don't want to put them on bypass. So you may occasionally palliate VSDs with a pulmonary artery band, but most of the time we would proceed to primary closure, either surgical or device closure. And the surgical treatment now has a very low mortality in infancy. Even more complicated cases of VSD associated with other defects still has a very low mortality. And now with intraoperative echo and careful monitoring in the operating room, there's a very low incidence of significant residual defects. But the long-term outcomes, at least for patients who were operated many years ago, this is a normal population and what you would expect mortality to be. This is a population of ventricular septal defects. These were patients who were identified in the 60s and 70s as part of the natural history study that was centered here, Dr. Natus and Dr. Feiler. So you can see that survival with ventricular septal defect is certainly worse than the general population. And some of these patients had pulmonary hypertension because the VSD wasn't closed, but that was a small number. Most of these were sudden unexpected deaths late after VSD closure or spontaneous closure, mostly surgical closure. So you can see that the long-term results, at least of patients who were identified then, are not ideal, not what we would expect from the normal population. I don't know what the data would be for somebody, identified in 2000 with a ventricular septal defect, because first of all, we don't have 25 years yet. But I don't know of those data being published at this point, but this is something that would be very interesting to look at, and look at patients who were identified between, say, 85 and 2000. This would be, this would give us 20, 30 years of follow-up where we could see what happened to that group. I mean, these patients were operated or identified, in a different era of surgery. The approach was different. Most of these would have had ventriculotomies to close the VSD as opposed to closing it through the tricuspid valve. Cardioplegia was not the same. Certainly postoperative management was not the same. So we don't know that this is what you would expect from patients operated today or even in the last 10 or 20 years. And it would be important for us to begin to figure that out. So any questions? If not, we can look at some examples.
You may have touched on that, but when we talk about conoventricular septal defects, do we see defects where the septum itself is fenestrated and there's a VSD in the septum, not necessarily the whole septum is absent or malaligned?
You mean in the infundibular septum, conal septum? Is that what you mean?
Yeah, and
the outlet septum.
Yeah.
There are occasional, most of the time when there are conal septal defects, it's really absence of the entire thing. And they're usually pretty good sized defects. But we have seen a few where there were relatively small holes within the infundibular septum. But I think that's really pretty uncommon. I think most of those, it's generally absence of the entire thing.
Gotcha.
Can you see, what do you see on your screen right now? There we go. Now, can you see the towel?
Yes.
Okay. I always forget exactly what I need to do, but I need to turn on the video so you can see my hand and that sort of thing.
Correct.
Okay, good. So we'll look at some specimens here. So here's our first one. We're looking at this again from the front. Here's right atrium. You can see typical right atrium here. This is the fossa area right there. There's a little foramen or secundum defect. Coronary sinus is here. There's the Bayesian valve. And so here's our tricuspid valve into the right ventricle. And you can see this is the septal leaflet of the tricuspid valve here. Here's the superior anterior leaflet. This is the commissure. Here's the papillary muscle of the conus up here. So this is all septal leaflet down here. This is anterior leaflet or superior leaflet up here. And you can see there's a big defect here that goes all the way back to the AV annulus. That's at the inlet part. Here's the diaphragmatic wall down here. Pulmonary valve is up here. So this is the outlet septum or infundibular septum. Here's the, again, the papillary muscle of the conus. So this is the inferior ramus. Superior ramus would go up here, and this is the infundibular or conal septum here. And you can see this defect extends right up to the papillary muscle of the conus. So it involves the membranous septum as well as the whole inlet septum back here. This is all missing all the way back down to the inferior wall here. So this is a big inlet or AV canal type of ventricular septal defect. And if we look at it from the left side, here you can see the fusion here between the septal leaflet of the tricuspid valve and the medial leaflet of the mitral valve. Normally, this would all be covered with muscle, and you wouldn't see that, even though that's present in everybody. We all have this, but you wouldn't see it unless you made a cut through this part of the heart, because this is covered with muscle. And you can see this is all missing, all the way back down to the diaphragmatic wall here. Here's posteromedial, anterolateral muscles in the left ventricle. Sorry, here's posteromedial, here's anterolateral. That's sort of a mid papillary muscle there for the posterior wall. And you can see this extends right up to the aortic valve. So the membranous septum, which would be right in there, there's the right coronary, and this is the non-coronary here. The membranous septum is missing here as well. So this is a big inlet or AV canal type of defect that goes all the way back to the AV annulus. And the conduction system in this would be running down here on the inferior muscular wall. There's no muscle up here, so you can't get the conduction system running through up here. It's going to go all the way back down there like in an AV canal defect and come around like this. So it's this area where the surgeons have to be careful about putting sutures in to create heart block in hearts like this. So that's an inlet or AV canal type defect. Now here's a little bigger heart. This patient survived for some time. Got to be a teenager, I think. Does it tell me? Yeah, 14. And this patient had Down syndrome. And again, you can see here's the fossa up here, superior vena cava coming in there. Inferior vena cava would have come in down here, coronary sinus. So here's our septal leaflet of the tricuspid valve. And here's the superior anterior leaflet up here. Here's papillary muscle of the conus right there. And you can see this is the superior ramus. The inferior ramus is here. Here's infundibular septum or conal septum here. And the pulmonary valve is up here. And so you can see there's a big defect back here at the commissure. Here's the septal leaflet here. Here's the anterior superior leaflet. Here's the commissure. And you can see this defect is right here centered at the commissure. And it has a little bulge here, a little pocket that's beginning to form from this part of the septal leaflet. So this is a big membranous defect with some extension into the muscle around it. Extends mostly inlet and toward the apex a little bit here. But this is a sizable defect. And if we look at this from the left ventricular side, here again, you can see here's the defect here. Here's right coronary. So this is the right coronary sinus and leaflet. Here's the non-coronary. Here's the trigone in between. And you can see that this is right below that. This centers right below this commissure. So that's where the membranous septum would be. So the membranous septum would be here, and this is missing. Now, this kind of defect, sometimes a lot of this is missing too. And then you can get prolapse of these two, one or both of these two leaflets into a membranous defect. In this country in Western Europe, it turns out that this is the most common type of defect that's associated with aortic leaflet prolapse. And you can have either right or non or both prolapsing into a membranous type of defect like this. So this is a big membranous ventricular septal defect. And as we said, these typically close by formation of an aneurysm. And so here's an example. We know this patient previously had a membranous defect, and then she went on to die of a blood dyscrasia, a leukemia disorder. And here you can see this area of fibrous tissue in here is all bound down around to the ventricular septum. Here's again the papillary muscle of the conus right here. So this is outlet septum up here. Here's pulmonary valve. And you can see how this septal leaflet here, this part of the septal leaflet has become entrapped and bound down to the septum there. And if we look from the other side, you can see this is where the defect was, and there's that little membranous aneurysm that's formed that's closed the defect. It's now completely closed. And there's some fibrous tissue here that's built up around it. Again, here's the right coronary, so this is the right coronary leaflet. Non-coronary leaflet, here's the commissure, here's the fibrous trigone right there, and this is where the membranous septum would be. And so this was a membranous ventricular septal defect that closed by formation of this little aneurysm. And there you can see I'm pushing out on that little bit of tissue here. This is the pocket that formed that closed the defect that incorporates part of the septal leaflet and then some other fibrous tissue around it. So those are inlet and membranous defects. Now here we have a little bit different arrangement. So here again, we're looking in the right ventricle. Right atrium is back here. Here's the tricuspid valve going back into the right atrium there. And so here's the septal leaflet. Here's the anterior leaflet there. Here's the papillary muscle of the conus right there where the anterior leaflet's attaching. And you can see instead of this defect being down in this part of the septum behind the septal leaflet, or here at the commissure between the anterior and septal leaflets, it's superior to that. It's above that. It's up here. Here's the superior ramus. This is the inferior ramus with the papillary muscle of the conus. And what's missing here is the conal septum or infundibular septum or outlet septum. So if we go back and look at this heart, for example, and compare them, here you can see this was our membranous defect, which was down here, whereas in the other heart here, you can see that this part of the septum down here is intact, down here below the papillary muscle of the conus, which would be this part down there where the defect is. And here's the infundibular septum up here. That's what's missing in this heart. You see, here's pulmonary valve up here. Here's pulmonary valve. This is infundibular septum. And in this heart, it's missing. So this is a conal septal defect or a doubly committed subarterial defect or subpulmonary defect. And you can see that it's missing because here's pulmonary valve leaflet, here's pulmonary valve leaflet, and this is aortic valve leaflet. Here's aortic valve leaflet. And you can see there's nothing in between them, just a little fibrous ridge here, which is really the annulus of the two valves that come together there. So you can see you go right from one leaflet to the other valve leaflet there with really nothing in between. So this is a outlet defect, a conal septal defect, doubly committed subarterial, subpulmonary, supracrystal, all of the above. And so it's here in the Y, between the two limbs of the septal band. And this is a prolapsing aortic valve leaflet. You can see how that leaflet just comes right, it can come right across because it's unsupported on this side and prolapse into the VSD. And if we look at it from the left ventricular side, you can see here's the right coronary. This is the non-coronary. Here's where a membranous defect would be, and that's intact here. So this is above that. This is an outlet defect right below the right coronary leaflet. And it's the right coronary leaflet here that would typically prolapse through the VSD and cause aortic insufficiency. In some places in the world, particularly in Asia, and this is the most commonly defect that's most commonly associated with aortic insufficiency. But these are relatively rare here and in Western Europe. And so the membranous defects are more commonly associated with aortic insufficiency here. So you can have absence of the infundibular septum, or we can have arrangements where the infundibular septum is in the wrong place. The VSD is in the same place. Here here's papillary muscle of the conus, so there's our defect right there. Here's the infundibular septum. It's not absent, it's just displaced. It's associated with the superior ramus instead of being here in the Y. And here's our aortic valve, which also overrides the septum a little bit, because the infundibular septum, instead of folding back like this to fill this VSD here, as it should have if it had rotated anti-clockwise enough, is more clockwise rotated than usual. And so it allows the aorta to override, produces subpulmonary obstruction. The pulmonary valve in this case is also abnormal. So this is Tetralogy of Fallot. So this is the same kind of defect. This one involves the membranous septum, because you can see that there's the continuity between the AV valves across the floor. Here's mitral, and there's tricuspid over there. So that is a membranous defect as well as this conal septal malalignment type of defect. So there you can see the narrowing of the right ventricular outflow tract, typical of tetralogy. Now, sometimes, not very often, but sometimes we can see the same kind of defect. And here it is again. Here's papillary muscle of the conus right here. So this is inferior ramus. This is superior ramus of septal band. Here's the defect. And here's infundibular septum right here. Aorta is right there. Pulmonary artery is right here. Here's pulmonary valve right here. And the aortic valve is just on the other side. So this is infundibular septum. It's displaced up here like the other one, but there's no outflow tract obstruction. So this is the kind of VSD that's been called an Eisenmenger VSD, not Eisenmenger syndrome, but Eisenmenger VSD, where it's like the VSD in tetralogy. There's the same kind of displacement of infundibular septum, but no pulmonary stenosis, a big pulmonary outflow tract up here. This actually looks like it was probably a bicuspid pulmonary valve, but no pulmonary stenosis. And these patients are at risk for developing pulmonary vascular disease. And then we can have the infundibular septum do the other thing here. Get this turned right way, yeah. So here's our right ventricle here. Here's again papillary muscle of the conus right here. This is not focusing very well. You want to zoom in a little bit? Zoom in. Yeah, there we go. That's a little better. So here's papillary muscle of the conus. So this is the inferior ramus. Here's superior ramus of septal band, and here's the pulmonary valve up here. But you get a hint that there is something here. It isn't completely absent. We don't see the aortic valve here. So there's a big pulmonary artery here. And if we look on the other side, here's the VSD again. Here's the aortic valve is right here. This is aortic valve leaflet right there. And this is the infundibular septum. So this is a posterior deviation, and you can see how it narrows the left ventricular outflow tract there between the medial mitral leaflet on this side and the conal or infundibular septum on the other side, causing subaortic obstruction. And this is, of course, associated with an interrupted aortic arch, and that's exactly what we have here. There's the ascending aorta. Here's the PA with the two branches, and then a big ductus here going into the descending aorta. So this is a posterior malalignment with interrupted aortic arch. And then we can have various kinds of muscular defects. So here's one right here. Here's from the right ventricular side. You can see here's, again, papillary muscle of the conus. Here's septal leaflet. The outflow is all, the basal septum, the membranous septum, the outflow septum are all intact. Here's a mid-muscular ventricular septal defect right here. Same thing from the LV side. This is probably conduction tissue that's probably the superior or anterior hemibundle that's passing across the defect there. So a mid-muscular defect. Here's one that's right at the apex, very apical. Here's our tricuspid valve here. Here's the outflow up here. Pulmonary valve is all the way up here. So this is way down at the apex, right at the apex. And there was an attempt to close this that wasn't successful. They actually did close it through an apical right ventriculotomy here, but the patch was taken off post-mortem. So this is an apical muscular defect. And then you can have other kinds of muscular defects. Here's our right ventricular side here, and there you can see this big sort of mid to basal muscular defect, but it doesn't go all the way back. There's muscle here between it and the annulus of the valves. So this is a little more basal muscular defect. And if we look at it from the LV side, you can see there may be we may be seeing a little bit of continuity here. So that may involve the membranous septum, but then has mostly a big muscular extension down toward the apex and a little bit anterior here. So various kinds of defects there. Let me just show you a couple of closures just so you can see what this looks like. This was a patient who had actually double outlet right ventricle. The aorta is on the other side of this. And so here you can see sutures. This was a patch closure of this, and you can see how it's completely endothelialized. You can see a little bit of the prosthetic material right there that's underneath this endothelialized part of it. And here from the LV side, you can see the patch here directed over toward the aorta. The aorta was above the right ventricle, so you can see how horizontal this is in that case. So this is what these patches end up looking like. They mostly endothelialized. You can often see the sutures around the edge. Here you can see it all the way around down here where this defect was closed. And then this is a device that was used to close a residual ventricular septal defect. Here you can see from the right side here. No, here's from the right side. Sorry, here, this is the right side. Here's one up here that was used to close a muscular defect. There you can see the left side of it. Here's the right side over here, how it's been deployed. And here's one that was used to close a more basal, more inlet type of defect. Here's part of it here. One of the arms went across the septum here. That left this residual defect there. And then the other part, the other arms, here's the waist in between. Here, the other arms over here, and you can see they've entrapped the tricuspid valve. So this is one of the potential problems with the basal VSD closures. You can see how this has entrapped this tricuspid valve, holding it mostly open in an open position. And then the last one I wanted to show you is this little apical defect. And this is a little device that's been put in this apical defect. This is a device you won't ever see anymore. This was an old Rashkin PDA occluder device. This was what Bill Rashkin invented to close ductuses, but these were actually quite good for muscular defects too. They aren't made anymore. And so here you can see from the left side, it has 3 legs instead of 4. So you can see here from the left side, so this was put in this very apical muscular ventricular septal defect. So those are some examples of ventricular septal defects. Anybody have any questions about anything? No questions? Okay.